Okay, moving down to the assessment of the lower leg, the foot and the ankle. There's a few points to note about the foot and ankle in particular, that they do form part of the kinematic chain, the lower limb kinematic chain. And as such, the foot and ankle complex has to be able to fulfill two mutually exclusive roles. It's got to be able to absorb forces at contact, at initial contact. So the whole structure needs to be a malleable structure, and it's also got to be able to impart thrust during the propulsive phase of gait. So during the later phase of the gait cycle, the foot and ankle needs to be a more rigid structure. Problems often associated with loading should be considered throughout the subjective examination. So if, for example, a patient comes in and tells you that it's a problem when they walk, that's not enough. You need to know at what phase of the gait cycle do they feel their symptoms. Is it during the loading phase? Is it during the propulsive phase? Is it during the swing phase, the non-weight bearing phase? As that can have very different implications and may lead you down a different route from an assessment point of view. Quick reminder of the bones of the foot. You can see the complexity of the foot here. We've got the talus that sits over here at the top. Underneath that, for creating the posterior pillar of the foot, is the calcaneus, and then the anterior pillar of the foot is created by the remaining tarsal bones, the navicular, cuboid, 3 cuneiform there, the 5 metatarsals, and then onto the phalanges. And the whole foot has to act as a coordinated structure. So dysfunction of one part of the foot can lead to dysfunction of the foot as a whole. Quick reminder of the ligaments. There's a lateral complex over here. We can see the anterior talofibular ligament, this small band. That's the most commonly injured ligament that we see. The calcaneofibular ligament over here, fairly commonly injured. And then over here we've then got the posterior tibiotalar ligament. Beneath that is the subtalar joint, which has its cervical ligament, and the lateral talocalcaneal ligament over here. Part of the functional ankle, we need to include the syndesmosis, the inferior tibiofibular joint syndesmosis. This is the syndesmosis down here, in which the fibula, the lower of the fibula and the tibia are held together very firmly by the short, tight ligamentous structures. Here's the medial complex. The medial complex includes the deltoid ligament, which is made up of the anterior tibiotalar ligament, the tibionavicular ligament, these long fibers that we can see here, the tibiocalcaneal portion, this large section here, and the posterior tibiotalar ligament. In addition to that, not only have we got the whole medial complex that supports the ankle, but there's also structures on the underside of the foot. There's the spring ligament, for example, the short plantar ligament that we can see here, and the long plantar ligament. They all create support to the whole medial arch of the foot. Need to remember that the foot is maintained in a certain architecture. We have longitudinal arches, the medial longitudinal arch, the transverse arch, that creates a vaulted appearance of the foot, and this vaulted appearance is important. The ability for the foot to change the height or the size of the vault is what leads to its ability to change from a rigid to a flexible structure. So observation of the shapes of the arches at rest is also an important component. Now, if we go on to the assessment proper, it follows the same format as any other assessment. We start off with a thorough subjective assessment. We need to identify the mechanism of injury. Was it an acute injury, or did it gradually come on? Is it posturally related? Is it when they weight bear, or is it when they non-weight bear? If it's an acute injury, was there any crepitus or a click or a crunch at any time? And if there was, is that significant? Was something damaged, was something ruptured, or was something fractured? Precise location of tender spots has to also be identified, as that can often give you an idea as to whether we might be needing to look at a fracture. As with anything else, we need to consider how the pain behaves, the severity, the irritability, and the nature of the pain. and also if there's any giving way, any collapse or any clicking around the foot and ankle. Again, the subjective follows a typical pattern of any other joint. You want to know what the nature of the symptoms are. Is it predominantly pain? Is it stiffness? Is there lots of swelling? The mechanism, you can't expand enough on the mechanism of injury. Is it associated with them repeatedly running, or is it standing, weight bearing? If it is during activity, does the footwear that they use make any difference? Does the ground surface on which they run, for example, if they're playing hockey on AstroTurf, is that worse than if they go jogging in the park on grass? The pain, again, the behaviour of the pain, when do they get it, how severe is it, does it impede with function, and is it associated with any swelling? If there's any traumatic history, an X-ray may be indicated, but we'll discuss this a little bit later when we look at the Ottawa rules for deciding whether an X-ray is indicated. As for all patients, we need to ask special questions. What's their general health like? Have they had any scans or imaging? Has there been any unexplained sudden weight loss, which can be obviously an issue? Any rheumatoid pathologies? Any drug treatment that they may be on, especially long-term corticosteroids or anticoagulants? Are there any neurological signs? So do they have paresthesia, anesthesia, and so on? At the end of your subjective assessment, you should be able to start to plan for the physical assessment, and you should have a fairly clear idea of the severity, irritability and nature of the problem. Now, the objective assessment again follows a typical pattern. We start off with observation, which starts as soon as the patient walks in. How are they walking? What posture are they holding? Is it an antalgic posture? Have a look. Is there any obvious bruising? Is there any redness? Is there any obvious atrophy or hypertrophy of muscles? And look at their postures, not just their foot postures, but also the postures further up the kinematic chain. And is that having an impact on their symptoms? We then move on to the range of movement and its variations. For example, we may start off with the range of movement to the ankle, the active range of movement to the ankle. We may need to move on to the passive ranges, passive ranges with overpressures, repeated. We modify it as appropriate. We then go on to the muscle length tests, and then your resisted muscle manual tests. Neurological tests are done as and when indicated, for example, dermatomes, myotomes, and neural mobility tests. And then finally we finish off with a series of special tests to attempt to implicate individual structures. Functional tests may be done early on in the objective assessment or may be left towards the end, but invariably it will need to include gait, walking gait, running gait, hopping, whatever it is the individual does under normal activity. So here we're going to look at the subcomponents of the objective assessment. Observations start off looking at posture. Do we have somebody who's got an excessively pronated foot, as we've got here, for example, in this case we can see the foot is rolled inwards, it's very, very heavily everted. You can see the arch is flattened awfully on this side. It has to a certain degree on this side, but it's much worse on this side. Or are we looking at somebody who's got a very rigid, very high arched foot? It has a pronated foot is an unlocked and a soft foot, and a high arched foot is typically a locked and rigid foot, and it has very different implications. This sort of foot will often lead to overuse problems, whereas this sort of foot will lead to shock absorbency problems. Look at their posture. What's their weight distribution like? Are they tending to favour one side? Do they tend to stand with one leg in a slightly different position, more externally rotated, internally rotated, and so on? Look at the state of the knees and the tibias, because that may well have an implication on the stresses that go on in the foot. If the hip is being held in internal rotation, for example, it could be forcing the foot into a pronated position. And then look further up the kinematic chain. Look at the levels of the iliac crests and the ASISs and PSISs, the buttock and knee creases. Is there any actual limb shortening or any relative limb shortening? So, for example, you can have somebody who's got a very, very heavily pronated foot on one side and a supinated foot on the other side. The pronated foot reduces limb height, whereas the supinated foot will lead to, or can lead to, an increased limb length. Okay, when we go into the ranges of motion, we need to consider not just the ankle joint, but we need to consider the joints that lead to inversion and eversion, so the subtalar joint and the mid-tarsal joint. The ankle joint is a typical uniaxial or hinge joint. We have dorsiflexion as a movement of which there is around 20 to 25 degrees. The range of movement should be similar whether the knee is flexed or extended. And then plantar flexion, we've got anywhere between 45 and 60 degrees, again irrespective of the knee position. The movements of inversion and eversion are composite movements, so they occur both at the subtalar joint and at the mid-tarsal joint. And at the subtalar joint, that's the talocalcaneal joint, we should see anywhere up to about 15 degrees of inversion and about 10 degrees of eversion. Whilst at the mid-tarsal joint, we have the movements of supination and pronation, anatomical supination and pronation, of which there's about 30 degrees during inversion and about 25 degrees during eversion. So inversion is generally more mobile than eversion. Now, the movements of calcaneal adduction and abduction and mid-tarsal supination and pronation are composite movements. I said they are accessory movements. The movements at the mid-tarsal joint and the subtalar joint cannot occur individually; they occur together, and they are interdependent. So loss of movement at the subtalar joint may lead to hypermobility of the mid-tarsal joint and vice versa. So it's important to assess those two joints together and thoroughly. Range of movements of the rest of the foot needs to be considered as well. Is there appropriate gliding of the intertarsal joints? Is there appropriate motion at the toe joints? Is there dorsiflexion, plantarflexion at the metatarsophalangeal joints? And these sorts of movements will vary from individual. Things like from individual to individual. Individuals such as dancers, for example, they require a great range of motion. They definitely require a minimum of 90 degrees of dorsiflexion at the big toe. Most people get away with slightly less, around 80, but dancers don't. So they have to be considered. Look at joints individually as required.